thank you for the invitation. And I'm going to have to remember to bring Dr. Hawley along. He's obviously showing more of his talents than just his surgical skills. He's managed to adjust lights and get slide presentations ready for us. So thank you for that. As Dr. Batsorf had said, my interest is, I'm a pediatric orthopedic surgeon, and my area of most interest is in treatment of spinal deformity. So I thought what we could do is open with a little bit of a case example of the type of patient that I commonly see. This is a 9-year-old who initially showed up actually in an emergency room, was having some gastritis, had an abdominal and chest x-ray, and this curve was noted. And really at that point, of course, the family kind of recognized that there had been a bump on the back that they just were observing. And the patient was then referred to us. This x-ray, we do some measurements of the curves, and this particular curve measured 70 degrees. The exam was actually quite unremarkable, at least from a neurologic assessment, in that there was no gross motor or sensory changes that we could identify. There was some trunk shift and this large rib prominence. So at 9, one of the key questions for us is, is this an idiopathic scoliosis, which is the most common kind of scoliosis we see, or does this represent some atypical curve pattern, and is there something more that we should be investigating? So hopefully today we'll cover a little bit more about what is the workup for scoliosis, and when do we raise the red flag for some sort of neural axis abnormality, what is the natural history, and what can be the treatment. This particular patient, we decided, did have a few things that stood out for us. One was a left-sided curve. So a typical idiopathic curve involves a right thoracic and left lumbar curve. There certainly can be a single thoracic or double thoracic or double major curve, but something that should raise some red flags is having a curve to the left. I should also point out that this is an x-ray done with us looking at the spine as a spine surgeon would, that is from behind. So left is to the left, right is to the right, and unlike a chest x-ray. We also take a look at the lateral film, and what we're looking for is what's the sagittal profile, and we'll go through why that's important. So this patient showed up, had an MRI done, and had this Chiari malformation with this cyst in the cervical spine as well as one in the thoracic spine. The family lived in the Las Vegas area and had a neurosurgical procedure consisting of a suboccipital decompression. And this was their follow-up MRI about 6 months later, showing some improvement in the cystic areas. What about the scoliosis? What happens when you have a curve of this size and the syrinx has been addressed? Well, if you look at the literature, it's a little bit confusing as to the guidelines to manage scoliosis after a syrinx has been addressed with a neurosurgical procedure. Most authors recommend some observation, but there are some recommendations based on the fact that larger curves in older patients tend to progress anyways. So in this case, this patient was observed for a year's time, and that curve went from a curve of 70 degrees to about 75 degrees. Just the overall gestalt, looking at this, you can see there's a little bit of a shift. Not huge change, but a change in a year's time. What do we do now? Well, we elected to go ahead and proceed with a posterior spinal fusion. And a posterior spinal fusion, the two main objectives here are to address the deformity that exists and prevent further progression, and really try to get this patient as aligned as possible. So we do that, and we'll talk about the constructs that we use with current spine instrumentation options. But the idea here is that we really want to make sure that this thoracic curve doesn't continue to progress throughout adult life, which then leads to problems with pulmonary function. Same patient, just kind of before and after with the sagittal profile. Again, we're going to spend a little time talking about the mechanism, the prevalence, the natural history, and management from the scoliosis perspective. I know you've heard from some fantastic speakers today about the direct treatment of syrinx and Arnold Chiari's, but this is going to focus a little bit more from the perspective of if the scoliosis is the presenting complaint or observation. What about the mechanism? Why does syrinx cause scoliosis? Well, the mechanism really isn't certain. There are several theories that have been floated about, and people have tried to look at the size of the Chiari malformation, the direction or the amount of herniation of the tonsils. But there has been some reports that the size or which side the syrinx expands to correlates with the convexity of the curve. And the thought is that there's some sort of cellular dysfunction in the cord leading to some trunk muscle dysfunction. One side is being more active or actually inactive. And then there has been at least one study that looked at this, where they did biopsies of the paraspinal muscles and showed evidence of denervation in the concavity. What is the prevalence of combined scoliosis and a syringomyelia? Well, if you look at patients who have scoliosis, that percentage is somewhere around 1% or less. This is an important thing because about 50% of the states do mandate school screening for scoliosis. And so the school nurse or physician will examine the patients with the Adams forward bend test looking for this rib prominence. My clinic is filled with patients who we call noliosis. You have some small asymmetry of their back. Someone is concerned about the scoliosis, and we get an X-ray. And the next question is, when we see some curves, what does this represent? Is this the idiopathic curve, or is this something more significant? On the flip side, I'm sure most of you in this room know that there's quite a wide range of the incidence of scoliosis in the setting of syringomyelia, and it probably falls somewhere in the middle here. Of at least in the spinal deformity literature, the reported incidence is somewhere between 25 and 80%. How about neurologic findings? Well, the patient that I introduced to you didn't have any neurologic findings, and that's actually quite common. If you look at the literature, it's all over the map. We have, for scoliosis associated, or rather syrinx associated scoliosis, neurologic findings somewhere fall between 0 and 89%. Our best guess is that about a third of all patients that have a syrinx-associated scoliosis do have neurologic findings, with some of the things that we always look for is asymmetric or absent abdominal reflexes, or some other obvious sign like a isolated cavus foot deformity. So, what about this left-sided curve? If you hear, most spine surgeons will immediately order an MRI for a left-sided curve in both juvenile and adolescent scoliosis. And the thought here is that there is a high rate of syringomyelia and other spinal cord anomalies like tethered cord. Actually, there was a study done not that long ago that showed that when MRI was done on all left-sided curves, the incidence was only about 7%. The big difference here is that more than 90% of idiopathic curves are right-sided. So, somewhere between 18 and 50% of all syrinx-associated scoliosis have a left curve. So there is definitely a higher incidence of left-sided curves, but it's actually quite low when you take all left-sided curves and account for them. All right, so here's something that is probably less well known, that is more important when assessing the X-ray and making a judgment about whether there should be concern of a syrinx. And this has to do with the sagittal profile. Scoliosis, at least idiopathic scoliosis, is a lordoscoliosis, meaning there is that typical, if you think of your own lumbar spine, your lower back has that kind of sway back. Well, in the thoracic spine, in someone who has scoliosis, if you follow the rib heads of the concavity, there's actually a little bit of an indentation. Whereas those patients that have a kyphotic deformity or lack of the hypokyphosis are much more likely. So this paper that came out in 2003 looked at the sagittal plane deformities, and what they identified was that in the syrinx-associated scoliosis, 75% of those patients had this appearance on their lateral X-ray, whereas 97% of the patients who had idiopathic scoliosis had that reversal. So if you see this, if we see this, this is the time we get an MRI. What are the other indications for an MRI? Well, we mentioned an abnormal curve pattern, curve to the left, abnormal neurologic findings, onset of scoliosis, less than 10 years old, we routinely order an MRI, and that's for curves more than 20 degrees. Or rapid progression. What is rapid progression? Generally, we expect when a curve is progressing that it's going to progress around a degree per month. If it progresses more than a degree per month over an extended period of time, this may be a cause for concern. Of course, we have to account for the changing rate of growth. So a 6-year-old isn't growing as, at the same rate as someone who is in their adolescent growth spurt, say a 12-year-old. And so there can be some variability in this rate of change that does not reflect a neurologic abnormality, simply reflects changes in the speed of growth. We've heard today about can a syrinx resolve spontaneously? Well, the secondary question is, can the syrinx-associated scoliosis also spontaneously resolve? The answer is yes, although the evidence for this is limited, and the frequency of this is actually not that common. So one of the studies that looked at this came out in 2001 in the British Journal of Bone and Joint Surgery, and they had 27 patients that had a syrinx or Chiari malformation-associated scoliosis that they observed over a 5-year period. And in those 27 patients, 14 patients had spontaneous decrease in the syrinx size. If you subsequently look at those 14 patients, 6 of those patients had improved scoliosis. So what's the takeaway? Well, 25% of the time scoliosis with the syrinx-associated association can spontaneously improve, but we're no better at predicting which of those patients that will occur in. We don't know if it has to do with the location of the cyst, the degree of herniation, or the size of the syrinx, or its collapse. When does scoliosis progress despite neurosurgical treatment? Another question about, and an important one, for example, the patient that I presented in the introduction, who had his decompression. How long do we wait before we make a decision to proceed with surgery? A couple different studies have looked at this. They've been relatively small patient populations, and there is some consensus that I think we can draw from these studies. In general, curves that are larger than about 40 degrees and in patients that are older than 10 years old have a high likelihood to progress despite their decompression. Is there any role for bracing for a syrinx-associated scoliosis? Well, there's not a lot of evidence for this either. The best study that I could find was put together was actually a compilation of 4 other studies. And they were able to identify 44 children. And they categorized these patients as those that did not have any treatment for their syrinx and got a brace, and those that had treatment for their syrinx and then also had a brace. And in each category, these patients, for the most part, progressed. So if you had no syrinx treatment and got a brace, 92% of the time, your curve progressed. If you had syrinx treatment and then got a brace, 67% of the time progressed. So again, the takeaway, bracing seems to be much less effective for managing scoliosis secondary to syrinx than it would be for idiopathic curves. Actually, the literature on treatment of idiopathic curves with bracing is somewhat mixed, although we have recently, we are expecting an NIH-controlled study report this year, which does show some level 1 evidence for the effectiveness of bracing in idiopathic scoliosis. We have yet to see that in syrinx-associated scoliosis. How about the surgical treatment? What are our options? And is it safe? And is it comparable in terms of outcome relative to the treatment for idiopathic scoliosis? Well, starting with the safety, the case reports that are out there are mostly historical. Prior to our era of advanced spinal cord monitoring, and prior to, in some cases, prior to an era where we had advanced imaging such as MRI. In those cases where scoliosis was treated and then there was identification of a syrinx or an Arnold Chiari, there have been some significant and permanent injuries, including delayed onset with paraplegia, bladder dysfunction, sensory changes, and there has been some reports in those cases of improvement after decompression. More current and relevant is what happens if the syrinx is treated first? Are we still at a greater risk in this patient population for some sort of neurologic injury? And the answer, at least from perusing the literature, is that we probably aren't, if a few things are confirmed. The first is the syrinx must be treated, and modern spinal cord monitoring, motor evoked potential monitoring, somatosensory evoked potential monitoring is available. So as far as I know, there are no reports of neurologic injury in that setting, where the syrinx was treated, decompressed, and then the spinal fusion was done with spinal cord monitoring. Does the scoliosis behave differently after the spinal instrumentation and fusion is complete? Well, we have 2 studies that have looked at this. And there is certainly a difference between curve pattern and curve behavior after fusion than in the idiopathic population. Ferguson found that 100% of the patients that were fused had at least 10 degrees of progression after fusion. And Bradley, more recently, also found a 36% rate of progression greater than 10 degrees. And I pulled this image from their study to emphasize another thing that is important here. This, in the past, one of the ways to address scoliosis was to approach it from the front and to try to do as limited a fusion as possible. That's this approach here. The advantage is that there's lots of motion segments that are preserved. However, we can have this, and it appears that this happens more frequently in the syrinx-associated scoliosis, and that's an adding on effect or a progression despite fusion. And in this case, they had to extend their fusion more. So the message is, in the syrinx-associated scoliosis, we need to consider going long, fusing more segments, more levels than we would in a idiopathic scoliosis. What else can we do to make things safer or to address some of the problems that we see? As I mentioned, these patients tend to have a kyphotic deformity. This is a patient that I treated that had one, and you can see, if you follow these rib heads, look how curved her kyphosis is in her thoracic spine. Well, we can now do prolonged traction done both in a hospital and home setting, which that alone doesn't provide a permanent improvement in their kyphosis, but this is going to be much easier to address with surgery than it would have been here. Another evolution of surgery in the last decade has been the use of screws, pedicle screws specifically. The advantages in a syrinx-associated scoliosis is that there's no entry into the spinal canal like you would for a sublaminar hook or wire. And so there's no change in the space. And there can be a higher density of these screws, so we can get very powerful correction. And we can take a very severe curve and make, like this patient of mine who had a severe idiopathic curve. But the point is that with this instrumentation, we can control both the back side of the spine, the posterior side of the spine, and in theory, with screws going all the way through all three columns of the spine up into the front, potentially control this problem of progression or crankshafting that isn't as easily addressed with the older constructs used in the 60s, 70s, and 80s. So, what are the conclusions? We can conclude that if there's a lack of hypokyphosis, this is a strong predictor of syrinx in a setting of scoliosis. Curve improvement after neurosurgical treatment is uncommon, and bracing isn't effective in this population. Scoliosis surgery is safe when preceded by neurosurgical care, and intraoperative monitoring is used. And finally, the syrinx-associated curves are more likely to progress after fusion than idiopathic curves. We should always consider fusing longer, and close follow-up is needed. Thank you.